So good afternoon, everyone. It's 15 minutes past 14 hours, and it's time for us to start this session. So thank you for attending today's session on death registration and mortality surveillance. My name is Pamela Kakande Nabhunzo. I'll be assisted by Beatrix to my right, who is from ESCAP. I'm from UNECA. So shortly, I'll introduce each of our speakers who will be speaking for 10 minutes. We'll have 5 speakers. Each will be speaking for 10 minutes. And there will be a time up to about 5 minutes of Q&A. If each of our speakers actually keeps time. If they don't, we'll keep all our questions and ask those questions at the end of the 5 presentations. So if you stick within your 10 minutes, at least you'll be able to gain 5 additional minutes for your question and answer. So we have a great group of presenters that we are going to start with. I'll start with the first presenter in the order in which they will be presenting. I'm going to introduce all of them. Then later, they will do their presentations so that you're not wondering who is seated there and who is that other one. So the first presenter or our first speaker will be Miss Scholastica King Kong, who will present a paper on application of the Adia Lopez method for assessing completeness of death registration in Kenya. Scholastica is at the right hand, is the manager demography at the Kenya National Bureau of Statistics, where she oversees the production, analysis, and dissemination of vital statistics data. She has extensive experience in managing major national statistics programs, including demographic and health surveys, censuses, and civil registration and vital statistics. Her work has significantly contributed to strengthening demographic and data systems and promoting the use of evidence for policy, planning, and development in Kenya. She's particularly interested in demographic methods, mortality analysis, and utilizing high-quality statistics to promote decision-making. Scholastica, I just wave to the audience. And our next speaker will be Dr. Amna Awan, who will present a paper on registering stillbirth in Pakistan. How far are we from making every baby count? Dr. Amnan works as a public health consultant at Health and Population Department in Punjab, Pakistan. She leads district-level epidemic control, disease surveillance, and real-time health statistics integration. Her research interests lie in health system strengthening, while her current work emphasizes using district health data to strengthen CRVS systems for more accurate and timely birth and death registration. So that's Dr. Amna, who will be our second speaker. And our third speaker will be Dr. Ketsom. He will help me to pronounce the second name. My apologies. So he will present a paper on closing data gaps, strengthening mortality surveillance in Laos, PDR. So Dr. Kate, that's his abbreviation. You just want to tell us pronounce the other name, just in case somebody remembers it. Dr. Kate is the Deputy Director General, Department of Hygiene and Health Promotion at the Ministry of Health in Laos. As a public health specialist, he provides guidance on health research, non-communicable diseases, community engagement, health policy, and primary health care development in Laos. He has over 20 years of experience at the government of Laos, UN agencies, and INGOS. So you're welcome, Dr. Ketty. Our fourth speaker will be Dr. Dan Kajungu. who will present a paper on harnessing the health and demographic surveillance system to transform death registration and mortality surveillance in Uganda. Dr. Dan is a public health specialist and biostatistician with over 15 years of experience in health systems, research, and population health in Africa. He serves as an executive director of the Makerere University Center for Health and Population Research, which oversees the Iganga Mayuge Health HDSS, that's a Health and Demographic Surveillance System in Uganda. He is also a senior lecturer at Stellenbosch University. Dr. Kajungu holds a PhD in public health and has led multi-country research initiatives in non-communicable diseases, maternal immunization, health informatics, civil registration and vital statistics, and One Health. He is actively engaged in regional and international research networks with a strong focus on generating and using longitudinal data to inform policy and improve health outcomes in low and middle income countries. We look forward to your presentation. Our last speaker will be Ms. Priki Proxy Ainomugisha, who will present a paper on counting every death, analyzing trends of death registration, timeliness, and completeness in Uganda. So Ms. Priki Proxy Ainomugisha is a dedicated Ugandan demographer, currently serving at the Uganda Bureau of Statistics, where she plays a key role in advancing the country's civil registration and vital statistics system. In her professional capacity, her work focuses on improving the registration of vital events, such as birth and death, ensuring data quality, providing technical support, supporting national planning and policy development, and promoting the use of demographic evidence in decision-making processes. So those are the 5 speakers that we'll be having this afternoon. And like we already mentioned, you will have 10 minutes. And we straight away will start with the first presentation by Ms. Scholastica. Please, you have the floor.
Thank you and good afternoon, everyone. I'm going to have a hard time.
Look at yours.
Oh yeah, I can just use mine. So as the many speakers spoke in the morning and the mid-section today, death registration in many African and Asia Pacific areas face incomplete and unreliable mortality data. Compared to birth registration, death registration is an event that has somehow been left behind when it comes to registration. Looking at now death registration, it's like we are flying partially blind, but not fully blind, because you have something to guide you, but you're not sure where you're headed to. So in Kenya, just like any other African country, we have various sources of death registration data. In 2018, between 2018 to 2019, there is a variation of death registration completeness. The ICDR gives it 60%, UNSD is giving 39%, and then the country level indicators are ranging between 48 to 39%. So various methods over the years are producing different statistics. So in Kenya, we use the direct method in estimating the death registration, but now we have other indirect methods that have come up and over the years have been used. So the generalized, the GGB method is one of them. Then we have the capture, recapture, and all these methods, they have their own limitations that accompany the results. So the Adair Lopez method has of completeness, where during its modeling, it used over 150 countries in data to just come up with this model that is going to be easily used to produce indirect estimates. So my study is focusing on how applicable is this methodology to Kenya when it comes to doing what? Estimating the completeness of death registration in Kenya at the national level and at the sub-national level, which we call the counties. So we have 47 counties in the country. So this method, there are two in one, where the first method involves including the under 5 mortality completeness, and then the second method is now excluding the under 5 mortality completeness. So the key inputs where we are going to, when using the model, is you have the registered deaths from the CR, and then now you have the reported deaths. In this case, I used 2019 because we had just done our census in 2019. So this is going to be my reported deaths. And then now we have the media population. Of course, from the census now I have almost accurate media population and not just the projections. And then from that, the percentage of the elderly, that's 65 plus. And then now the under 5 mortality measures, which is now from the same census. And the results are being now compared to what we are getting from now the 2019 Vital Statistics Report. We'll look at now the sex differentials and also contrast between ASAL. So ASAL means the arid and semi-arid areas in the country, and then the non-ASALs are the non-semi-arid and arid areas. So what are the results showing? From now the direct estimation, the completeness in 2019 stood at 39.1. So direct is now the registered deaths over the projected deaths based from the census result. And then in model 1, where now the under 5 mortality is included, the Adair-Lopez method shows about 59% of completeness. So this is close to what ICDR produced. And then the male completeness was 60, while the female was 58.7. So when you look at what we get from using the direct method, it shows that there's either some underestimation based on the current Kenyan data condition, because the indirect estimation is giving slightly higher figures. Then looking at now the lower level, sorry. Now, looking at the lower levels, we have variation in the counties, which is what we expect to produce. However, when you go to the lower levels, you find in some subnationals, the male registration is higher, but in other subnationals, the female registration is higher than the males. We know over years the literature shows that male death registration is or should be higher as compared to the female registration. So this is an indication, either one, at the national level, because it's giving what literature is supposed shows over time, is more plausible at national level. But when you go lower to the sub-national level, you find that the indicators are very shaky and very few counties are, what do we call, like in line with what literature is saying. So, and then going to the second model. Am I in the second? Yeah. Going to the second model, we have where now the, oh, I didn't include, okay, let me just discuss it. Now in model 2, the same where now under 5 mortality is not included, it still shows the same results. However, in an African setting, we know how different the angle of the curve when it comes to mortality. It's not consistent across all the ages. It's much higher in the younger ages and also in the older ages. That's how the U curve, I'm sorry if I'm being statistical a bit, but the U curve in mortality, where in the younger years, under 5 is higher, and then it declines and then starts rising again in the older ages. So for the Adair-Lopez methodology, it has assumed that mortality is constant across the countries. But this, especially in Asia and African countries, we know it's not really plausible. So when you look at some of the counties, higher performing counties, we have the Nyeri, Machakos, Embu, Mombasa, Kiambu, and Uasin Gishu. These are the non-ASAL counties where the death registration completeness is 70, 80s and above. And this is where you find the big infrastructure, the big hospitals, the centralization and decentralization of infrastructure. So we have the CR offices at the lower ground, and everyone is can access the services for the registration services. Then now in other counties where the issue of geographical inequalities is seen, we have a lower predicted completeness of even below 30%. So when you look at these ASAL counties, some of their cultures also dictates how the performance is going to look like. And then I just mentioned briefly about the sex differences, where the male completeness overall was slightly higher at the national level, but now when you go to the sub-national level, there's slightly differentiation. So in just to summarize the results, we are seeing that the age structure, the registration practices, and the quality of the data strongly influence the predicted completeness. So in my discussion, I said that this method is very useful for estimating death registration. It's an additional literature, an additional method to what has been existing to come up with the completeness. However, the quality of the inputs really affect what we are going to have. For example, in under 5 mortality, when we are developing the under 5 mortality for the census, we used inputs from now the demographic and health surveys output. Now remember, this is a survey on its own. It has its own challenges and quality issues, and then you're introducing it to another indicator. It carries all this quality or biasness to it, and then from there you're taking it again to be another input to another methodology. So the quality over time will signal that we need to look at the inputs cleanly. And then the gap between direct and modeled estimates simply means that there are assumptions which have been used over time that need routine assessment of the completeness. So county level patterns which point out to the structure differences in ASAL areas shows that we require strengthening of this vital statistics system. And this one is mostly now looking at the policy implication of this result from the CR offices. They need to formulate some of the policies that will increase coverage and completeness of these indicators. So what are the recommendations? So this is a good tool that can be used as an alternative to just complement the completeness of registration within a country. Whether it can be used at lower levels, it's maybe country to country, depending on the inputs, that how strong your or how high the quality of your inputs are. And then we'll need to strengthen the quality of the inputs. That's now from the census side, from the survey side, how we are going to increase the quality. And then death notification and death registration. In some countries, one means the same. In others, you have to notify death and then register it. So when we are reporting in one area, notification is same to registration, and in the other one, we are saying registration is only at the point of certification. Where are we in defining notification and registration timeliness? And then age reporting. This one is mostly, especially in now the ASAL areas, where you find a mother does not even know the age of her child or even their own age. When this birth occurred, when this death occurred, how old was this person? So age reporting is also something we need to strengthen. And even training when we're doing data collection, both at the registration level, at the census level, and the survey level. And then this one is maintaining the census and registration sources, the consistency between these two. Again, notification vis-a-vis registration and certification. Then as a country, we need to look at how to prioritize these ASAL areas in terms of leaving no one behind, ensuring whether it's a nomadic or a pastoralic community, every death that has occurred when you're out in the fields is reported and registered. And then we need to look at further validation, just looking at over the years if this methodology is going to hold forth and how it's comparing with other existing methods and other research that has been done over the years. I think that's about that. I have more than 5 minutes, so I can just say there was a comment from the reviewers that we do the sensitivity analysis for the inputs, and that is yet to be done, and because we got the comments close to the forum. But yes, hopefully this one will be done after this. Thank you very much.
So thank you very much. Thank you very much, Scholastic, for your presentation. And I must say you've slightly short over time. So let's keep questions for Scholastic to the last part when we have the panel discussion and have the next presenter. That's Dr. Amna. And my prayer and hope is you stick within 10 minutes, right? Over to you.
Good morning, everyone. I am Dr. Amna, and I work in Health and Population Department in Punjab, Pakistan. Stillbirth is termed a neglected stepchild of CRVS, but very important for those of us working in public health because it is an important indicator to assess the quality and coverage of antenatal and intrapartum care. However, stillbirth registration and reporting is unfortunately a low priority in Pakistan due to absence of regulations to register and report. We know through surveys that prevalence of stillbirth is very high, is as high as 52 stillbirths per 1,000 live births in Pakistan, as compared to the global figures of 18 per 1,000 live births. But in the absence of reliable data, we need to rely on surveys, which in turn are dependent on funding and governmental priority. If something is not counted, it cannot be measured. So, in absence of figures, we cannot study contextual factors leading to stillbirths, cannot make international comparisons, and above all, cannot influence policymakers and funders who need figures to make decisions and roll out funds, obviously. So this is how my research came into being, how it was born. I conducted this study to study the stillbirth reporting and registration process against international benchmarks in Pakistan and to study the facilitators and barriers towards achieving these benchmarks. I would like to acknowledge SCAP and CART, without whom this research wouldn't have been possible. And I would also like to thank District Health Authority Gujranwala for their support in bringing out and helping me out in conducting this research. So our research was conducted in District Gujranwala of Pakistan, which is a blend of urban and rural areas. The study population comprised of healthcare workers, which were working in the government sector, and who were involved in the reporting and recording process of stillbirths. We conducted a purposive sampling to select participants for our focus group discussions and interviews. We developed a semi-structured questionnaire for our FDGs and interviews, and which was based on the CVS ID toolkit. We used it as a benchmark to measure the actual practices that were going on in the field. The interviews were conducted both in Punjabi and Urdu and were recorded in audio and transcribed manually. MS Excel then was then used to code the interviews, and subsequently 8 themes were developed, which I would be discussing in the next slide. Yes. In the first theme, we discussed the definitions, and we realized that there was a lack of standardization in defining stillbirths. Some were classifying them as neonatal deaths, and they did not know what is the criteria to define the stillbirths. And then there were in the next theme, under the next theme, we realized that there was discrepancies in the methods of reporting stillbirths as well. Some were reporting verbally, some were using telephones, some were uploading on the DHIS, some were then there was another tool, EMR, that they were using. The stillbirths which were being reported were just in the areas where the lady health workers were working. So if a lady health worker wasn't there, she passed away, or she had been transferred, because this program has stopped inducting new recruiting new health workers. So from that area, there is no method how to report stillbirths from that area, which was also very unfortunate. And it is the stillbirths were being reported within the monthly cycle. So if a stillbirth occurred at the first of a month, that birth would be reported on the second or third of next month. So there was a lot of time lag between the reporting. It was not a real time. And no secondary data was collected, like what the parents were doing, what were the occupations, how many siblings were there. There was no information about those stillbirths. And then there was no medical certificate that was required to register a stillbirth. The place of registration, however, was district office. We found that this was closer to the benchmarks. This was the only indicator, in fact, that was met in our criteria. And as the stillbirths were buried outside the graveyards, so though no medical certificate was required or no evidence was required of how where the stillbirths occurred or who was responsible, or no such data was available. So the facilitators we found, which was the second part of a study, was that there was a strong community trust in LHWs, with lady health workers, which can be used to strengthen this program. And then there are these monthly meetings going on at the community level, which can be used to give the on-the-job trainings. And there were ultrasound facilities at almost all the primary healthcare facilities, which can be used for better defining and developing criteria for defining the stillbirths. And the barriers were there was lack of training commitment at the high levels. There was system fragmentation, which I've discussed previously. There were multiple channels of reporting the stillbirths, and then there were app failures. Sometimes the internet wasn't there at the community level, and such issues were prevalent. So we found that stillbirth reporting and recording practices fell short in almost all the major benchmarks. We identified barriers that create an ecosystem where stillbirth reporting is low, priority inconsistent, and structurally constrained. System fragmentation also emerges as a significant barrier to accurate stillbirth reporting, as I discussed in my last slide. And there was a lot of parallel reporting channels, and such fragmentation increases the likelihood of data loss, duplication, and discrepancies, particularly when transition between systems is poorly coordinated. Existing studies, they do examine the causes of stillbirth, but none assess the issue systematically and define a legal or regulatory framework, which we have attempted to address in my study. The study timing was presented a limitation because there was an ongoing program of privatization going on in the district where I was working. So we had to limit our focus group discussions to the lady health workers. We could not assess the other health personnel that were working in the same sphere, because they had been either transferred out or they were in the they were being phased out to other programs. So I recommend the recommendations that we have come up is that we need to develop a coordinated system-wide approach to improve the stillbirth reporting mechanism in my country. We need to strengthen the enforcements, and we need to have some definitions that the lay workers need to use in their data collection. And we need to have some legal and laws enforcements which should define the responsibilities as to who is responsible for reporting or not reporting stillbirths. And as I mentioned earlier, we need some follow-up studies to study the community perceptions and how they feel about registering the stillbirths, and what problems they are facing on reporting or recording the stillbirths. That's it. That's me conducting my focus group discussions. Thank you so much.
Okay, thank you, Dr. Amna. She served us 2 minutes, and we can give her some two quick questions if anybody has a question for her. Yes, please. Go ahead.
Thanks for that presentation. I wanted to know specifically to you on what the law says on stillbirth and what the practice is. Does your country consider a stillbirth as a birth or as a death? Or how do you then give parents the legal document as pertains stillbirth and especially on the disposal? Thanks.
Thank you. That's a very valid question. In fact, when I was discussing this with my group, they asked the same question. So there is no law currently as to whether it comes under, because it's not a domain of the CRVS currently, and I think it's not anywhere in the world right now. So it's a domain of the health department, and we consider it as a death. It comes under the death, but there is no law work, like I don't have to give a certificate to anyone if I'm the doctor dealing with the mother who gave birth to a stillbirth child. So this is your first question, and the second one was um,
To dispose, or how, if I want to dispose a stillborn, what do I do?
the certificate. No,
What document?
we have no document. So this was part of the finding. We don't give any document. There was nothing we found from the health workers. They said there's no document required because there is no burial place for the stillborn child. So nothing is required. We are giving nothing. So that was a finding of the study. Yeah.
Okay, thank you. And I think you have one more question from the online audience. Frontline health workers are indispensable for improving the netting of stillbirth. Has Pakistan added definitions of vital events in the CRVS law?
A definition of stillbirths?
Of vital events in the CRVS law?
So my study as the vital events, yes. So there is a law. So it's either a birth or a death. So stillborn, it does not cover does not come under that law. So it's not a birth and it's not a death. So that's the dilemma. Because for a baby to be considered alive, it needs to have taken a breath. So it's not a birth technically, and if it's not registered, it's not a birth, so it's not a death either. That's the dilemma. Food for thought.
I think you have one more. Then I think that will be the last, and then we keep the others for the end.
Yes, so please. Dr. Nani, for me, it's a follow-up on what you have just mentioned, and I'm curious to know what is it that the government is doing, because if you say it's a dilemma, then what is the country doing about that?
Nothing, unfortunately. Nothing is being done. That's what I think this is how, because we need to do more research so that the policymakers know, because there is no funding, unfortunately. I think government only looks at the areas where there is funding. So as long we don't have data, we cannot attract funders to work on it. So nothing is being done currently. So it's very unfortunate. Yeah.
African.
Yeah. Yeah. Throwing.
Okay, thank you so much, Dr. Anani. That was a good one. And we have another good one coming up. Dr. Ketty, I think you will introduce the topic, the paper. Over to you.
Thank you very much, and very good afternoon to everyone, and those who access to the forum from different locations were online. And this is a good opportunity for me and our team to share what we want to do and try to do to provide policy development in Lao PDR. Some of you might want to know, where is Lao PDR? Lao PDR is just 55 minutes by flight from Bangkok to my capital city, that is Vientiane. And this is the concept of primary healthcare, because of the government would like to use the preventions and health promotion to improve health sector, especially CRVS in Lao PDR. And Lao PDR is with a population of 7.5 million, is a low-income countries. About 65 to 68% of the population live in rural area. And Lao PDR is still characterized by a weak healthcare system and especially health information system. And this is very important for Lao PDR to capture community death, which account for more than 90% of the death occur in the communities. This is because of cultures and traditional practices. They want to bring their parent, their family member to die at home. So this is difficult for us to do death registrations. So death were under report in official statistic, underscoring weakness of the data. To address this gap, and we try to do a feasibility study and to improve CV registration and vital statistic is very important. This is capacity development for whole of the country. So we get support from WHO country office team members and decide to roll out mortality surveillance model, integrating facility and also community data into the district health information system to base national health information management system. What we want to do is to enhance health plannings or evidence-based funding for domestic fund or resource allocations from the central government. And this information, reliable information on, can you go back? Yeah, this is important to help us to monitor universal health coverage and also sustainable development goal in Lao PDR. And we can understand the burden of disease in Lao PDR. There are compound challenges in Lao PDR because we know that most of that occur in the communities, which is difficult to register into the system. There is no systematic reporting mechanism at the moment, and that's why we are trying to do this. And cause of that largely unknowns. So what we want to do is institutionalize report of medical certificate of cause of death, MCCOD, in hospital. This is one size. Code with international classification of disease, 10 editions or ICD-10s, and introducing community mortality, surveillance through village chief and village health volunteer, complemented by verbal autopsy to ascertain probable cause of death. That is the aim of our feasibility study or the pilot that we are perform. So what we do is, at two sites, the facility base or in the hospital or at health facility, we use MCCOD introduced nationwide, especially among the medical doctors who work in the health facility. But this is, we are focusing on the one province that we are doing pilotings. And ICD-10's coding implemented during the pilotings and putting this information into the district health information system. And we employ some kind of staff in health facility to do data entry and reporting into the dashboard in the health system informations. And the second size of the data collection is community and village chief notify the death, because this is very specific context in Lao PDR. When you have funeral at home, you have to invite the village chief or village leader, and then village leader notify this, and the village leader will get contact with the village health volunteers. We also train village health volunteer and ask them to report back to the health center, where health center staff will do data entry. And we do verbal autopsy first and do data entry into the DHIS2 system. And that is the work that the concept that we are building. And the capacity development or training, before doing data collection, we train 550 health workers, including physicians and health information staff, to complete MCC/OD accurately and to code using ICD-10. In addition, 741 village health volunteer and village chief were trained to support community death notifications. We deploy DHS2 trackers module nationwide in hospital to capture MCC/OD. For community death, we build an existing practices where family notify death to the village chief, who is an elected village level authority responsible for community administrations and resident welfare. And this is the work that we have done. What we found is that mortality report by the system established both health facility and community is seen as an importance of local authority, but it's not there before. Community death report nearly twice during the piloting periods, and verbal autopsy and verbal cause of death information from the community death. As you can see in this slide, the table show that we do this feasibility in Vientiane province, which is about 100 kilometers far from Vientiane capital to the north. And in 2024, compared to 2025, you see the populations of the Vientiane province. And the most interesting is the community death report into the health information management system is increased double. For example, 468 to 896, and estimate the completeness is about double. And in this slide display community death surveillance system. This is the total community death notified, 2,711. This is the number of notified death with detail enters into the system. And this is the number of notified death by district. Vientiane province, not Vientiane capital. Vientiane capital is the capital city of Lao PDR, but Vientiane province is a province. And in this province comprised of 11 districts, you can see the numbers of the total numbers of death notified by district is emerged after the study. And we found that genders distinguished by male and females, 40% for females, and this is death proportions. And the cause of death comparisons, for example, this is the cause of death report, and this is accidents, numbers of. But this is not about the detail, but this is about procedure, how the community report the death into the system, and how can we build this for the next phase and roll out over the countries. We use this concept and approach, but this is just finished, and we are going to organize a roundtable discussions and how can we disseminate this finding to more line ministry, because most of this we have to involve other line ministry and development partner. This cannot be achieved by the health sector alone, because, for example, Ministry of Home Affairs, they are doing CRVS at the moment, and they are taking care or in charge of administration over the country. So registration, birth registration is belong to them, but we can support to each other to overcome these barriers and bridging the gap. And discussion, I think most of the speaker, they mentions quite similar. We need to improve competence of the mortality reporting. The availability of cause of death information is very important to provide and support the policy maker and to draw more attention to provide domestic fund to support. And real-time monitoring through dashboard is very important. How can we see the burden of disease during the year? And also integration pathway to national CRVS. And what we have learned from this is community engagement is very important in terms of death registration in the community. Digital tool, we need to improve And also continuing training is required for those who work in the health facility to do data entry and reporting into the DSIS2 system, the cause of death and certifications. Interministerial collaboration and action is very important also. So we draw a set of actionable recommendations after this feasibility study. For example, we need to scale up mortality surveillance by expanding community death notifications and verbal autopsies to additional province, and strengthening cause of death certification by continuing training and provide supportive supervisions for MCCOD completions and ICD-10 coding in the health facility, and also institutionalize verbal autopsy, strengthening CRVS integration, and sustain system monitoring using the DSIS2. And one thing that we need to mention here that we integrated into the primary healthcare concept, because we in Lao PDR, we have 8,405 villages over the country, and each villages they have village health volunteer, where we can use and support the local authority accountability or ownership and leadership to connect with the village health committees to link with health center. This is among frontline health workers. They can do mortality registration at the community, where health facility is better because they have scientific knowledge. They can be trained and easily using the fixed site and deploy data entry into the system. And that is my last slide. We thank to our data collector, villages, village health volunteer, and local authority, and especially for those who enrolled in our piloting study. So thank you very much for the attention. Thank you.
Thank you. So those are interesting findings from Laos PDR. We'll get questions during the question and answer session. I think let's move to the next presentation from Dr. Dan Kajungu. He prefers to stand. Good afternoon.
And good evening, good morning, wherever you are. Yes, so where do I go now? Yes, that's me. I just want to highlight my co-authors down here. They include Charapati, Betty, Arozia Sochora. I don't know that Stephen Kasumba is in here. No, and then Eileen and the rest. She has already introduced me, so I don't have much time. I want to talk about harnessing HDSS infrastructure, transform community death registration and mortality surveillance in Uganda. I will talk about the HDSS briefly, and I think these are the acknowledgements I want to make. I want to highlight the district leadership, the village health team members, the community members, and of course the Ministry of Health and CDC Foundation Data for Health, who really supported this work. Now, we know that mortality statistics by sex, age, cause of death are vital for policy, we all know in this room. But we know that also the COVID pandemic really exposed this need in many countries, especially in sub-Saharan Africa. And in Uganda, civil registration is premised under the Registration of Persons Act, which is within the NIRA. NIRA is the National Identification Registration Authority of Uganda, which is the CRVS agency, or the CR agency of Uganda. And we have seen that 20% of deaths are registered in Uganda, which is far below the global standard of 80. There is the CRVS Strategic Action Plan, which aims to strengthen the registration ecosystem. Now, HDSS, I said I would talk about it. HDSS is Health and Demographic Surveillance Site, and it's a continuous monitoring, continuous population-based monitoring of events, death, birth, migration, and all those. In Uganda, the HDSS we're talking about is the Iganga Mayuge HDSS, which I lead. It's under Makerere University. And we use the VHTs, who are village health team workers, and the local leaders to report a death that happens in the community to us. And then we go and do a verbal autopsy at the HDSS level. That is for us as HDSS. And so we have used what we have. We have the protocols, we have the SOPs, and those are the ones that we really try to see how can the government or the NIRA adapt to improve their CRVS. The aim of this project was to integrate HDSS practices and procedures into the CRVS framework to decentralize and enhance community death registration, completeness, and mortality surveillance. Community death registration is key here. We had 2 phases, one in 2022 and 23, and then another one, 23 and 24. The first phase, we looked at the HDSS. We worked with the NERA, applied their forms within our HDSS, where we work with our scouts, we call them scouts, the VHTs and the local council, to really be the ones to notify, register, so that we see how, if we integrated the NERA forms within our system. We had our forms, but we brought in the NERA forms. And during that time, we developed the materials, the SOPs for work, and we trained, of course. Then the second phase, we went outside. In addition to just, we went outside HDSS, where we are not involved. Of course, it is the normal population. It is local councils out there without the HDSS controlling the whole space. And these ones, we had to train them also on verbal autopsy and conducting verbal autopsies. For us, HDSS to do verbal autopsy, it was a piece of cake for us. But outside, we need to train them on verbal autopsies. These were 117 villages across the different sub-counties, 7 sub-counties. And then we see, this was to tell us if we had to scale up, we recommend scale up. We can't scale up what we do in the HDSS, we need to scale up something that they are used to as a government or as a public. So this is in Eastern Uganda, and HDSS has been around since 2004. The phase 1 was including all HDSS villages. Then we added the 117 villages, which are non-HDSS. The partners are there, CDC Foundation, CDC, Data for Swiss Tropical Institute, TPH, and then those are the dates. So the HDSS population is not different from the national population, and they say that Uganda is in a phase of demographic transition, and of course we had urban and rural and urban communities. What happens, the protocol says that if a death occurs, the VHT is notified by the family, and this VHT will visit the household, they offer their condolences, and they fill what they call the death notification record, notification form. Then they take it to the LC, who endorses that yes, this death has happened, and then that death notification form is submitted to a sub-county for where there is a NERA focal person who registers it in the NERA system and then sent to the district or to get into the MVRS, which is the Mobile Vital Records system, which is now the NERA records. So what we did also, we did capacity strengthening. We trained for 4 days. We trained these guys, the VHTs, the chairpersons, the different people at different cadres. And we're looking at the death reporting protocol, the completion of the forms, verbal autopsy for those who were supposed to conduct verbal autopsy at some level. And this was done only in phase 2, the training for verbal autopsy, because phase 1 was HDSS and we didn't train on verbal autopsies. We developed the SOPs, and then data quality was reviewed at different levels. Now, in the end, we registered for the 2 phases, we registered 300, or almost 30,000 deaths from 7 sub-counties and 117 villages after in phase 2 of expansion. When you look at coverage, in terms of death registration completeness, we found in phase 1 and phase 2 for the HDSS, in phase 1 for the HDSS, both male and female, the completeness was at 73. In phase 2, it was 79 and 72, male and female respectively. And by the way, this is 3 to 4 times improvement over the national coverage. And this completeness, we estimated it using her method, which she talked about, but it is Adele Lopez's method. She knows more about that than myself. Other mortality indicators is life expectancy. This is not news to you. We know that the female live longer than men, and mortality risk was higher in male than female. And this is consistent with all all countries. Yeah. So what did we find in terms of qualitative? We found that these VHTs, or who we call scouts, are very interested, and they love it because it gives them some respect in the community. They love to do it. So the community awareness was a problem, so we find it's really important. It was it's an important finding. We need to, and we recommend it to the NERA group to really make sure they amplify it. They felt that the process of getting death certificate is now easier because we can really work with the people who know, and to not have to go to the district to really apply. The process can start from the people they know. There were similarities in terms of the VHTs. They really were proud of being part of this, and the families loved that. What we found is that we needed to train more VHTs operated this, it was unfamiliar territory for them, some of them, especially those outside the HDSS. So we need more training. And the VA training, of course, was included in phase 2. There were enablers. The HDSS network, community network, reduced the resistance. And of course, we have created that trust with them. And then the infrastructure is there. The VHT infrastructure is there. The partnership with the government really made it legitimate, more legitimate, because we had the authority of government. SOPs really helped us in reducing errors, and there was community. There were barriers in terms of distance, visiting some homes are very far. So the literacy levels, as I mentioned earlier, if we need to scale up, we needed fresh sensitization for communities and limited infrastructure, especially for some areas which are really and is hard to reach. What can we say? There was successful integration of HDS protocols in Uganda's CRVS framework, and actually the government has taken it up. The issue of decentralization, the VHT reported reporting mechanism reduced barriers and improved accessibility because we had training, they were trained, there was HDSS supervision and all that. Of course, this is Igang and Maige, those are 2 districts, not Uganda has 146 districts. So it would be hard for us to sit here and start we can generate, but it is something that we think we can recommend to be tried in other districts. We need to look at things like cost effectiveness, scalability analysis, and also if we are to do national scale up. I don't know whether I want to go through this, but what I can say at village level, the death notification can be completed, and the notification record can be completed. We can review the forms at sub-county, we can conduct several autopsies, and then at different levels, all these structures I'm mentioning, they are available already in the government in Uganda. So this model would support the CRVS strategy very well. Leveraging existing structures and community-based notification protocols meaningfully enhances death registration completeness and mortality surveillance in Uganda. It is scalable, replicable, and we can use it to strengthen CRVS. The HDSS experience can improve CRVS if we try to integrate it. We can improve CRVS registration and fact of death completion. It allows additional capture of population cause of death because now we're going to have probable cause of death. I have to add that whenever I'm in the room, I don't know whether they are physicians. Probable cause of death, that's what verbal autopsy gives us. Yeah, so we train them, then we can use it for population estimates. Yeah, we recommend integration, establish sustainable financing. Of course, we tell government, please put some money in this project. It is possible. And then invest in capacity building, of course, for that community for verbal autopsy to be conducted. And look at the scalability assessment. And yep, I thank this CDC Foundation, AFNet. Yeah, Nira is here. Who is from Nira? No, Kasumba is not here. Okay, thank you so much. And thank you so much for allowing me to present to you and listening to me.
Thank you very much. That was a very concise presentation with a lot of information in it and a lot to learn. I would like to ask if you have a question or two at this point for Dan. Okay, Alain, and then we'll have Elvis.
Thank you very much, Dr. Daniel. Very exciting. I'll be very quick and brief. Would you like to share with us like 2 things about issues of ethical issues regarding this, and also the component of confidentiality in terms of as people are collecting this information for the VHTs? And then the proposal of scalability is very good, but I'm just curious to know, given what is happening in the low-income countries now beyond Uganda, scalability, given your perspective, how possible is it in terms of what needs exactly to be done, particularly in terms of that? Thank you.
Thank you. Dan, you want to take that, or you take or the other one?
I didn't write it down, maybe if I forget. Yeah, I will start maybe with the second one. I know why you're asking the first one. It's That is too scientific. But the second one is about scalability. And I think it's an important point to look at, especially if we are to work with the policymakers and inform them. As you saw here, all those groups involved, apart from the HDSs, they are already within government structures. The VHTs are under the Ministry of Health. They are involved in government programs. If in Uganda, we have what we call policy development model. The local council leaders, they are government, they are in local government, they are within the government. When you go to the sub-county, the health assistant at sub-county is within the government. NIRA, and actually that's why we are saying we're working with NIRA to see how can we really work with you to see that this, you don't need to invent the wheel. You don't have to recruit new cadres to do this work. What you need to do maybe is to add it on their KPIs and make sure that they are able to do that. For example, a VHT, they should report how many deaths have occurred. Have they occurred in their community? They report the deaths that have occurred, but the question would be how many have we notified within the specified period and how many have been registered. So the thing is to strengthen what is already available. And what we did as we just give them the motivation that really we've been doing this as HDSs. So you as a government, you can't wait to do it. They always say, when government, there's a lot of money involved, budget for it. What you don't count, you can't plan for it. So that is the one thing we tell them. And the issue of ethics. Ethics, I don't know at what angle you want it, but what we do, we have involved different. We make sure there's consent, for example. You can't just interview someone about a death that occurred in his household without seeking their consent. So we do consent at household head level, but also at the person who is really going to talk to you. Another thing is that we don't conduct our verbal autopsy immediately. That's where I think the issue would be. Registering a death is by law. You don't need the consent. But for a verbal autopsy, we give them some time. Our procedures say give them like 4 weeks to mourn, and then you come with the condolences and also talk to them. Yeah, I think that is the level of ethics. The rest is for publication purposes. We are really, this is a program thing. It was not, for HDS we have our ethical approvals and whatever, but for this work, it is government involved. They're the ones who, the custodians of ethics, they're the custodians of regulations. So we're working with them to really make sure that those are some dynamics we need to handle.
Wow, that's a good one. And I think I had a similar question with Alan, but I'll keep mine and then I'll give the floor to Elvis. Please
thank you. Thank you, Madam. Dr. Dan, thank you for your presentation. I'm Elvis from Cameroon. I would like to know if in your country death notification is mandatory. If somebody refuses to notify death, what would they do to him, for example?
Unfortunately, there's no one from NIRA here. It's a requirement. If you don't report, I don't know whether they are, which country is similar to Uganda that can tell us what happens in their country. In Kenya, what do you do?
So you have to notify a death because that is what is going to give you a burial permit. Yeah. Ideally, you cannot bury a dead person without the burial permit. However, it's happening. People, especially in those far, large regions where the local administration is very far away from the people, you find they just bury and continue. You find their culture within 24 hours, you need to have buried someone. So, and in one end, to get to where they'll get a burial permit is 2 days away. So they just bury and forget.
Yeah, thank you so much.
Thank you so much.
I can tell you that in Uganda, we don't need a burial permit. So you know how great it is now. So it's not a mandatory, it's not a requirement. Thank you so much.
Okay, although the law requires that you must notify, it's not enforced, it's not strict. So a death can happen and it's you go ahead with the burial and that's it. But at least within the health facilities, if that death occurred in a health facility, at least you'll have that record, which we then will look at as some of the notifications that have happened. So that question actually leads us very well into the next presentation by Ms. Priki Ainomgisha, who is also going to talk about death registration within the same country, Uganda. And I believe as she presents, she will be responding to part of that question. So over to you, Priki, and please keep the 10 minutes. Thank you.
Good afternoon, ladies and gentlemen. Yes, that's me. Pamela had already introduced me. I will just go straight to my topic. My research topic was on counting every death, trend analysis, focusing on timeliness and completeness of death registration in Uganda for the period 2020 to 2024. That's our country, Uganda, with administrative units, and it's having what my colleague had already mentioned, the 146 districts, inclusive 11 cities. Republic of Uganda is located in East Africa and lies astride the equator. And the population is at 45.9 according to National Population Housing Census, the recent census that we conducted. Then our CBR, that's crude birth rate, it is at 33.2 birth per 1,000 persons. Then the crude death rate, it is at 5 deaths per 1,000 persons. Timeliness of death registration in Uganda. In Uganda, any event that is registered within 30 days, any death event that is registered within 30 days, it is classified as timely registration. Then above 30 days, but within 1 year, it is classified as death registration, late death registration. Then any death that is registered beyond 1 year, that is delayed death registration. In Uganda, due to low public awareness on the importance of death registration and weak enforcement of laws and policies, then there is also lack of integrated systems. This has created more challenges in timeliness and completeness of death statistics in the country, and it has reduced the usefulness for national development, global reporting, and SDGs progress. That's why you can see that our completeness death registration rate, it is at 3.9, according to our first Ugandan Vital Statistics Report 2024. Our study employed the following research methods. We used descriptive analysis using secondary administrative data from national systems, that is the MVRS system that is used by NERA, that is mobile records system. And we used that registered death for a period of 2020 to 2024. And this is what we analyzed using Stata. Then we applied trend analysis method to determine the patterns in timeliness and completeness. I also applied a binary logistic regression model to determine the factors associated with timely death registration. These are the results from our study. We are having 3 different lines here, different colors. This is a graph showing trends of timeliness in death registration. As you can see, the downer line, the blue line, okay, that is for timely death registration. And from the year 2023, you can see an increase from 3.6% to 7.2% in 2024. That was an increase in timely death registration. Then the next line, which is orange, you can also see an increase, and it's indicating late death registration from 2023. We had 26%, and it increased to 34.7% in 2024. And this could have impacted or had got an effect on the green line that laid death registration. The green line is indicating that delayed death registration. You can see a decrease from the year 2023. There was a decrease from 70% to 58%. So the increase of timely death registration and late death registration led to the decrease of delayed death registration. The next result, it shows death registration by age and sex for the year 2024. And our graph is showing that there are more older males. If you can have a look at the age from 40 years plus, there were more older males registered compared to their counterparts, compared to the young ones. And also you can also have a look and see that we are registering more males compared to females. And as we move forward, you will get to see the reasons why, or maybe what is causing that gap. The next one is showing trends of death registration completeness from the year 2020 to 2024. You can see that we moved from 0.2 in the year 2020 up to 5.9. That is in the year 2023. And then it dropped to 3.9% in 2024. And this, I could attribute this increase up to 5.9, maybe because of the World Bank support NIRA had. We will get to see that as we move forward. Then we try to get some of the determinants, the correlates of death registration. These are some of the determinants that we are significant to death registration. We have age at death, which was significant. We have site of occurrence. Site of occurrence, that's where the death occurred, whether community or health facility. Then we also have place of residence. And this shows that just like I had shown in the recent graph, the previous graph, where we're seeing that there were more older males being registered than the female, than the young ones, or where we were showing there were more older males being registered compared to females. Then also we look at the site of occurrence, where the death in the health facility is more likely to be registered compared to the death that takes place in the community. Then for the place of residence, I'm giving you all this discussion, it's ahead. For the place of residence, it has also contributed to disparities in registration practices, where variations are likely to be driven by differences in access to registration services, awareness levels, and administrative efficiency. In conclusion, these findings highlight the need for targeted interventions that improve access, raise awareness, and strengthen registration systems, particularly for community death. Then our study had some limitations. There was low death registration coverage. So we're depending on the quality of administrative data, which was not sufficient enough, but that was due to underreporting and late entries. Then the recommendations for our study: more emphasis should be put on raising public awareness to understand the importance of death registration for both young and old, instead of concentrating on only old people, we need to also concentrate on young people. Hence, generating a reliable mortality statistics and inform health policies, resource allocation, and monitoring of national and global development commitments. Then we also need to ensure that our systems are integrated, our CRVS systems, between the National Statistics Office and other CRVS stakeholders. Then there is need for continuous capacity building for all the CRVS stakeholders so as to improve the death registration timeliness and completeness. Then we will be able to produce and disseminate the quality death statistics. Our next steps to be taken as a country or on behalf of NSO, we are trying to support NERA and other CRVS stakeholders to see how we can raise public awareness to understand, for the public to understand the importance of registration in the country. Then we are also engaging different CRVS stakeholders to integrate our data systems, all of them, all the CRVS stakeholders, so that we can easily access this data timely and improve the quality of death statistics in the country. Then also we are also planning to have continuous capacity building for all the CRVS stakeholders still. And our death registration in the country, we believe it will improve. These are the acknowledgements. I would like to acknowledge all these institutions. I would like to appreciate our supervisors, Dr. Allen Kabagenyi and Lillian Siziba from Zimbabwe. Those were my supervisors. And I also would like to appreciate UNECA team, Pamela Kakande, and Mr. William Muhava for your support. I really appreciate. Then I also appreciate my employer, Uganda Bureau of Statistics, for giving me an opportunity and allowing me for all this time to be here and participate in this. Then I also appreciate NERA and the government of Uganda at large. I thank you.
Thank you. So thank you to all the presenters. There were 5 of them, and at least we've been able to make it within time and also remain with time for the plenary session where you'll be asking questions and they should be able to give us some responses to those questions. Just by way of reminding us, we started with a presentation on methodology for assessing completeness of death registration. Then we went into stillbirth, registering stillbirth. Then we went to strengthening mortality surveillance. And then we came to strengthening health demographic surveillance sites to transform death registration. And then we wound up, I don't know what's the right word, is with death registration as a case of a country with very low death registration. How does this relate with what we have just gone through, the existing methods, processes, and systems that are in place? So I would like to open up the floor for any questions to Scholastica, Dr. Katie Priki, Dr. Amnam, and then Dr. Dan. So I'll start at the back, then we'll come here to 3 questions first. Please go ahead.
Yes, thank you so much. My name is Yefta Remwa from Uganda, working with Makerere University Corporation for Research. And my question goes to the presenter number 1. Thank you so much for your presentation. It was good. There's something that interested me, because in your model, you looked at what I picked. It's like you concentrated on gender, which was sex, to see the differences or the disaggregation for the differences that are coming with completeness. I would want to employ you. What do you think, if at all, you could look at area of residence of these people? What would you think? Would you think that we could see variabilities if we consider other factors like the household socioeconomic statuses? Maybe, who knows, if we try to look at different socioeconomic statuses, maybe we can assume, we can hypothetically say that maybe people who are from the first quintiles compared to those to lower quintiles, are we seeing some differences? I think that could interest more your study. And also, lastly, looking at other factors like the level of education, because when you look at literature, some countries and some settings, we see that households that are well educated or have had the opportunity of being educated, we see different proportions. I don't know. I leave it as that. It was just an highlight. But thank you so much.
Thank you. I think let's take a round of questions, then you will respond. I think he was next, then her, and then you'll be the fourth.
Okay, thank you. My name is Charles, and I have questions for two presenters. The first one is
Scholastica.
So I missed a bit of your introduction presentation, but I want to know the data you used. Which year was it from? And also, if it's from 2019 to present, do you think the impact of COVID-19 might have influenced their registration completeness? Yeah. And then the second question goes to the last presenter. You started off with completeness of registration in your country is 3.9%, and in the trend analysis, I saw 7.9%, 70-something percent. But those percentages, what numbers do they represent? How many deaths were captured within the period that you're looking at? And then also, with the method that you used, you had three outcomes: early registration, late registration, and delayed registration. And at the end of the day, you dichotomized it. And I'm thinking maybe it's a comment, maybe you should consider using a survival analysis or a time event history analysis. Because if a death happens, it's registered on the first day, and the death is registered maybe on the, in terms of late registration, a death is registered on the 31st day, and a death is also registered on the 365 days. You classify all of them as delayed registration, and I don't think that's fair because the time is too wide.
Thank you. The next.
Thank you to all of the presenters. You've done a good job. My name is Jean More, Editor for Health. I have a question for three. Dr. Dan, I wanted to know, you've mentioned at one point the HDSS was actually linked to your CRVS system, but at the end of the recommendation, you recommended that it's linked. So I felt like, did you imply that during the course of your data collection of the project, you were able to send the documents to the registration authority? But my specific question on that particular point is, were you paying for the interviews, the verbal autopsies? Again, were you actually paying for, that this is HDSS, so this extra work at this point, were you paying to move those documents to NIRA for actual registration? Okay. I'm talking about sustainability here. The other question is it's not a question actually, it's Dr. Amnam, I don't know whether I got your name correct. When you mentioned the dilemma in that your country is not doing anything on stillbirths registration, and we know how important having these statistics is, but I wanted to recommend something you can actually look for. The Data for Health program has developed the legal review toolkit. You might not be doing a legal review But that chapter 4 of that toolkit actually does explain how countries should go about stillbirth reporting. You might want to look for it to just get some ideas on how to go about it, even in general practice without a legal review. But I think there's something you can do out of this project to change the course of stillbirth reporting in your country, and kudos for beginning that. Then I have a question for Scholar, and it's you can see me behind the blue tent later. I wanted to know what you said about adjusting for under 5 mortality and age-specific mortality rates, given the low death registration completeness, both the 2019 census, the last census for Kenya, as well as the vital statistics reports for Kenya over the years, is always between 44 to 47. So how would you compare that? Because it needs to inform the mortality rates for other ages. And also, did you consider for specific mortality, for example, the burden of HIV or this? Did you find it important? Thank you.
Okay, thank you. We have the last question from him.
Thank you. Good afternoon. Madam Moderator, thank you for allowing me to ask you a few questions. First of all, it's my observation from the esteemed group of panelists who presented the papers. In my long course of my career, I'm 71. So I've seen all this reporting which was done manually over the course of my career. So it looks like it is still manually been done in most countries, right? So I also realized that only one speaker did say, I think the gentleman from Laos, he mentioned about ICD-10 and also CRVS, okay? The two aspects of modernizing CRVS reporting systems. The other speakers generally spoke about their method of collecting data, which has been in progress for many years now. It's still the same, I think so. So I was thinking, in terms of strengthening CRVS and modernizing CRVS, what are the steps being taken by countries in implementing electronic systems, for example, in hospital settings and EMR system, which can generally improve surveillance of mortality statistics in hospitals? As we all know, garbage codes using ICD is in fact, and it was before, still the main cause of collecting wrong mortality statistics. So what do you think, what do the panelists think about modernizing your methods of collecting rather than still going on, employing manual methods of data collection for mortality statistics? And maybe you can give us some views on how your countries are performing in terms of modernizing CRVS systems. Thank you.
Okay, thank you. You want to give in this round or in the next round? They are saying they will forget, but I'll just give one. Please, you'll come in the next round. So for this round, I just want to add one more question to Dr. Kate. You said your team demonstrated that integrating community death notification, verbal autopsy, medical certification of cause of death into the DHIS2-based HMIS nearly doubled community death reporting and markedly improved completeness. From a program implementation perspective, what operational adjustments or capacity building strategies proved most critical for sustaining this improved reporting flow, particularly in terms of supporting the village chiefs, the health volunteers, and the health facility staff to consistently use those digital tools and maintain the reporting timeliness across the diverse districts? So I'll start with Sikola to respond, and then in this order.
Yeah, before I forget, and thank you very much. I don't know if it's professor or doctor, because one of the comments I just scribbled down when everyone was presenting. The recommendation is strengthen the system. When we are writing proposals to our government and donors, one of the problem is always lack of funds. So in the CR space, strengthen the system has become lack of funds for us. So how are we going to strengthen this? And one of the things you've said is modernization of CRVS. I will not answer you because we are still manual. And when we want to modernize, lack of funds is one of the issues. So we are there. And we've tried thinking about mobile registration. Then you hear not every local administration has a mobile phone. The government has to provide one. Then you hear internet is a problem, even in the health facility. So we are all looking to how we can modernize, especially in now our low-income countries. So I'll go with the first question from Uganda on exploring other differentials. Well, in my presentation, the paper focuses on sex differential and also subnational differential, and it's because of how the model is. So if you want to look at area of the residencies, the social economic status, and any level of education, so this will mean all these different segregations that you want, you come up with their specific under 5 mortality by level of education. And we know when it comes to mortality, even getting the differentials in rural urban is a bit of a challenge, because now where is peri-urban, especially if your law does not clearly define what peri-urban is. And this, again, total fertility rates for those in higher and lower, it is possible if you're doing modeling, but it's a lot of work. And there's always someone who will start. So I've started and I'll pass the baton to my fellow Kenyans to do the further analysis. Then on the second on the year, I only focused on 2019 because that's where we have the actual reported deaths from the household based on the census. So I know of someone who is doing 2020 to 2024 as their master's thesis, and I cannot wait to see if there's going to be any fluctuations, especially on the impact of COVID. Then on adjusting of under 5 mortality, there was serious underreporting in the census. Yes, we did adjust for that, and that's one of the weaknesses of the inputs, because already you're using an adjusted figure as your input. The burden of HIV, yes, in the paper I looked at it, we have about 6.8% of causes of death, HIV being the cause of death in 2019. So there's a slight indication that the burden of HIV has been counted in as one of the causes of death within that period in the population. Yeah. Thank you. I think I've answered all the questions.
You go next, Dr. Kate.
Regarding electronic system or more innovations to do more death registration is very important. But look at the context specific in Lao PDR. We have a compound challenges. For example, internet coverage is only 70 to 80% that can cover over the countries. And also, we have to work with other line ministry also. For example, Ministry of Home Affairs, they are in charge of administrations over the country. But the outcome of the death registration is expected to obtain by the health system. And that is we have to work with them. Many countries, and of course, Laos is one country that we are trying to overcome this. The ministry, other ministry, they want to work like a silo. They want to work on their own priorities. But the mandate that we are going to work together is less. So we talk many times that multi-sectoral collaboration and actions at subnational level, it doesn't happen. But looking back to the COVID-19 outbreak, when the government commands lockdown, for example, the line ministry, they comply to the government commands. Yeah, that is very important. And then I talk in the high level official. We have to take this opportunity before this window of opportunity close. This is an approach that multi-sectoral collaborations within the CRVS. And that is very important for Laos to step out to get accurate information for immunization, for social welfare, for health insurance and social protections, for example. And to make this sustainability, I just come to your point that we need to work seriously on this matter, because if we want to graduate from low income country, we need to get accurate information that how can we use this program based funding and allocation to the health system. To make this sustainability, I think look at the capacity development, look at the context of the specific context in Lao PDR. And now we are trying to work with the line ministry, identify the role and increase ownership and leadership within the line ministry and local authority within this context, CRVS, for example, and also working with the development partner, because we don't have enough capacity and we need technical support from the development partner, especially WHO, for example. We usually use WHO strategy on burden of disease and CRVS, and also the government commitment, policy commitment should be there at the high policy level, should be committed to support the system. Yeah.
Okay, thank you very much. I think, Preke, you're next.
Thank you. Somebody asked me a question from Ghana concerning the numbers. Yes, in this summary, I could not put in the numbers. That's why I decided to use the percentages. When you need the numbers, you will get to see the final research paper. Then there is where you mentioned that you shouldn't have used maybe, okay, I can apply another method that you mentioned. It's okay, since we are still working, learning doesn't stop. So we can still apply it and we get to see the outcome. Thank you.
Thank you.
Thank you, Jean, for your, I think it was more of a comment than a question. And in fact, the CRVS toolkit that you're mentioning, I used it in my research to develop the questions, my research questions, and I use it as a benchmark. And thanks to the CART program that I'm part of, I was actually able to connect with the authors. Tana was she was kind enough to connect with them, and I had an online meeting with them. They were at different parts of the world, and it was very overwhelming, and I was honored that they took out time and they helped me. I discussed my questions with them, and this is what CART can do to your research. So really grateful for this opportunity.
Thank you, Dr. Dan.
Thank you so much. Thank you, moderator, and Jean, my sister from Kenya. You raised a very important question of sustainability and integration. Those are two key issues, and you're asking about payments. I'm not going to sit here and tell you what we do in the HDSS. That is it's not going to help anyone. But what I want to share is what happened when we went outside the HDSS, and looked at the district as organic as it is, what happens there. These VHTs are already there. How they deal with them, they know how they deal with them. They don't pay them. They are not actually paid for the work they do. So notifying a death is like one addition to what they already do. And they already have the structures, they have forms they do. So what we are telling them is that you can tap into what is existing to do that. I'll give you an example. When we came to verbal autopsies, we trained the sub-county-based health assistants, and we're telling them, you see, for us, when we come to a household, we give them condolence, we give them a bowl of soap, what. They said, please don't tell us that. For us, we know where we are going to get this information. Don't give us any money for that. We are going to do this, because when we start giving money or giving condolence, it's not sustainable. So that's one thing we learned from them. Like, don't tell us about what you give. That's what you do in your DSS. For us as government, or as people in the system, we know what happens. And that really reinforces the the need for sustainability and integration of this. I like the fact that someone is talking about digitalization. And I'm very sad again that there's no one from NIRA here. We advocated for digitalization of their forms, the death notification form, Form 12 of NIRA. And we said, can we digitalize it and make sure it is, we use, because people have these gadgets. They have, the VHTs have, they could digitalize it and they do that. But they said the law requires that someone puts a signature on the paper. And that law has not been changed. So they're working on legal reform to change that. So, but again, when you look at the Ministry of Health, they have tried to do digitalization by having the MCCD app. I think the MCCD app, there's in the DHIS2, where the clinicians go and enter the information and then they determine the cause of death and that. So for Ministry of Health, if the death happens in the facility where they are serious, they do that. They use the electronic form, and there's a lot of some level of interoperability. Now, from this discussion, we've seen that Ministry of Health is communicating with NIRA. They have sent their death records to NIRA, and now the Ministry of Health has another level, which is the ECHIS. It's called Electronic Community Health Information System, and we found that they capture the death notification form on there, on those VHTs. They capture it electronically. Now the discussion is how will NIRA use it? NIRA is the CRVS agency, agency. Are they going to accept it? And we're still in that discussion with them. Can you please accept this information? They say, but you see, there has to be the declarant has to say, someone has to endorse, a witness has to say, they need people's signature, need people's thumbprints. So those are some of the issues I have with legal people. I don't know whether there's a lawyer here. But I think that is something that we are pointing to as saying, advocating for digitalization of notification forms. Please let there be interoperability, and we shall have somehow a smoother system. Thank you so much. These are very interesting questions, and I can speak up tomorrow, but you'll not allow me.
He's a lecturer. In his bio, I think I saw senior lecturer. So he's a teacher, and you're not teachers. So thank you very much. And we had thought we'd have a second round of questions, but we'll just have two burning ones from her. And then there will be yours, and then we'll read the one online. Because be brief, don't give many. The burning one of the many.
Okay, thank you for giving me the floor. I will try to be as brief as possible, as the subject was really interesting. So I have so many questions for presentators, but some have already been about. So for the first presentator, I have a question about the pertinence of the method when in your case you have an actual census. In our case, we have been 20 years without a census. So is the method can be applied in this context? This is the question. For the third presentator, I think they have already asked about the network challenge, because I saw that the country is rural a lot. So do you face rural network challenge? And for the volunteer, as for the third and the fourth presentator, where they have other activities, because in my country, for example, we are working with community health workers. That's how we call them. And it seems they have a number of activity is just increasing. We started with the malaria, after the tuberculosis, now the civil registration. They don't have any legal statutes, and some matters of motivation, incitation started to arise. So is it the case in your studies? And my last question is about Uganda. I don't yet understand, because there was two the deaf registration completeness, because I have about 20 in the first presentation, and then it was 3.5. Maybe is the problem of methodology, or it was not the same indicators that was presented? I'm a little
Thank you. I
confused.
saw that as well. So we have the last question.
Hello.
Who are awake?
This is for our third presenter from Lao. You noted that female death registration was lower. During your pilot period, did you find any findings to explain this? And did you have considerations to build in gender responsive training, considering rates of sexual and gender-based violence are pretty high? Thank you.
Okay, thank you. I think we have some 2 questions online, but we are at the top of the hour now. Can I request for 5 minutes for us to just go overboard a little? So the first question online is for Dr. Dan. Thank you for your excellent presentation. I heard about extending the attribution of probable cause of death from the VA to the death registry. Could you please explain it a bit? Apologies if I misunderstood. And then, hello, my colleagues. From Egypt, head of vital strategy. I want to ask Dr. Dan, you know that I don't want to read the way it's written. That's how it's written. How do you use the 2 methods to improve estimation of population and the method used to estimate population, if normal method or projection by growth rate? It's difficult to read it, but I also want to request that be very brief, 1 minute, and then Dr. Katie, 1 minute, because we have requested for 5 minutes.
So it's me, I'm standing between you, between you and your heart and your living. Should I start with online? The second question, I didn't get it well, but I want to emphasize on the first question. At least I had it, and this is a question that must be a doctor who has asked that question. The issue of the verbal autopsy cause of death, it is probable cause of death, not, and you can't take it to the lawyer to court and say this is the cause of death. It is probable, and it's only applied at population level estimation, not at individual. That is the difference we have. And it's only used when we don't have access to the medically certified cause of death, isn't it? That is the clarification I would like to make. The second one, I didn't really get it very well. Let me go to the lady in the room. I'm still within. Now, for you wanted to know the incentivization, how. Now, for the, I don't know whether I got you very well. You want to see whether these community health workers, if it is more work and.
I think now, Dr. Dan, you'll get back to her.
I want to give you just one statistic. In a village, if you look at a month, they can have like 5 deaths. This is not too much work for the man to do. Just those are the only deaths where they have to include. That is the increment on their work. So even 5 deaths in a month is too much. Some villages don't have deaths in a month. So it is small addition, but people tend to really exaggerate it. But it's small addition on their work. So I don't see it as really a lot of work to cry over. Yeah, thank you.
Dr. Kate?
Yeah, 2 questions. And first one is, do I have any limitation in terms of networking in the community level, working with the village health volunteer and health committees? That is, yes, of course, especially during the monsoon seasons, geographic access, we miss connections, and the birth registration, death registrations, or others nutrition screening is delayed because of geographic access and also mountainous area and difficult to access to the system. That is one thing. For the genders disproportions for death registration, this is a very important question based on our assumptions at the moment. The possibility is because of non-communicable disease, cardiovascular disease mostly occur among men, and also road traffic accident in Laopedia is very high. And we should not proud that Laopedia is the champion of alcohol consumptions in the Southeast Asia, that it is 11.6 liter per person per year. And this is a highly commitment in Laopedia, high level official. So we don't know yet. We need to explore more this why the report in the communities to this proportion between male and female is
Okay.
not. Yeah.
Thank you, Dr. Kate. And just to wrap it up all from the presentations and the discussion around the room is that from the 5 research papers that we have listened to, it's very clear that for us to improve death registration, we must work on having some legal reforms within the countries, improve on digitization, ensure digitization of the systems, ensure systems are integrated, and then decentralization touching the aspect of using the community workers. And of course, out of all this, we have the vital statistics that comes out, which now speaks to our methodologies. And all these are key drivers for accelerating death registration in Africa and the Asia Pacific region. So I thank you all for your active participation and making this session successful. I think it's successful. So let's clap for ourselves. And so after the hand clap, we would like to welcome you to the UNCC Gardens Cafe. It's on the lower ground floor for an informal social gathering where we continue to ask questions and continue to discuss as much as possible. We haven't been able to ask some questions. I also had questions, but I didn't get the opportunity to ask. Yeah, so we will discuss. So welcome and thank you for accepting to add the extra 5 minutes. They've become 6. Thank you. Have a good evening. We'll see you tomorrow.
Thank you,
Bye.
moderator.